Hello. Cases of morphology and flow. We're going to discuss the last case of a 43 years old woman with a breast implant of silicone presenting 10 years after the cosmetic operation with a breast implant diffusion. An FNA was performed as well as capsular biopsy, and the cells were examined by either morphology and flow cytometry. So the first cycle of the quiz problem was whether these cases, you can see here, describe the cells with cytoplasm with abundant vacuolation, eccentric nuclei, and groups stuck together. What are the options of a case of implant seroma, as we call it? And the options provided are breast adenocarcinoma, primary breast lymphoma, implant-associated anaplastic large cell lymphoma, and implant benign seroma. Why do we provide this here to discuss? What is the reasons this are provided here to discuss in this case? And these options are provided because in cases of blast implants, it was observed several years ago that there are rare adverse sequelae, and one of these neoplasms arising was anaplastic large cell lymphoma, which is an option that is provided among the others. And if a woman notices swelling, fluid, or unexpected changes in breast shape, should go to her doctor, and her doctor should provide the diagnosis of a late breast seroma after silicone implantation and analyze the fluid. And the main question would be whether we have a breast implant associated anaplastic large cell lymphoma. We understand that 1 million women worldwide receive breast implants annually, so this is a rare sequelae. But even rare should be faced and diagnosed. And what should be the proper diagnostic procedure? The proper diagnostic procedure should be an FNA and examination primarily of the cells in the FNA. And the first option, suspicion, would be a breast implant associated anaplastic large cell lymphoma. And FNA of the effusion provides adequate specimen for the analysis. And the method should be either cytology as well as immunocytochemistry and, of course, flow cytometry. So we can see the morphology of the cells in a right GIMSA stain here of a malignant effusion with anaplastic large cell lymphoma. And we can see the cells vacuolated, but they don't resemble exactly the previous cells. They don't have eccentric nuclei, they are not foamy, and of course, you see the phenotype, it is positive for CD30. So we have to diagnose an anaplastic large cell lymphoma by CD30 primary and T cell antigens. What is the case we face here? So we're provided flow cytometry. And when we're provided flow cytometry, we see primarily a CD45 population of cells, positive. We don't see CD45 negative cells, as there should be the case of a non-hemopoietic tumor, as a breast cell adenocarcinoma. We see here in the second plot that we have CD4 positive. And CD4 positive is positive in cells with low side scatter, high side scatter. We can see we have T4 lymphocytes and we have CD4 positive cells with high side scatter. Should it be an anaplastic large cell lymphoma? It could be possible because many anaplastic lymphomas have CD4 positive. But it is not a proof. A proof would be CD30. And you can see that CD30 is negative. Equally negative is cytoplasmic CD3 in the high scatter cells, which are supposed to be the abnormal cells, while mature small lymphocytes have cytoplasmic CD3 positive, as expected, as well as other antigens concerning B cells are negative, like CD79A should be positive in a primary B non-Hodgkin lymphoma of the breast. What about other antigens of T cell series should be positive in anaplastic large cell lymphoma? CD2, we can see here, has a positivity. So what should it be here? Should it be a T cell lymphoma? Even CD5 here. Can we exclude a T cell lymphoproliferative disorder here? Can we exclude a B cell? I can see that we don't have CD19 or CD20 against a B cell. What about other antigens? We can see, as expected, keratin to be negative, but we can see here we have a bright positivity of CD64, CD14, and HLA-DR. These antigens point to monocytic macrophage histiocytic series, along with CD16, again, point to macrophages. So this is a phenotype of monocytes. And if we go back, we can see again that though anaplastic large cells look like monocytes, the case here, and we can see pathology resembling of monocytes, as we can see that the cells have foamy cytoplasm. We can go back and have a look again in morphology. So we get again to see these cells. Do they look as monocytes? Eggs? They look like. And immunophenotype similarly proves that these cells are monocytes. Should they be monocytes? What are the relations of monocytes and silicon implants? When we look up at the literature, we see in vitro interactions between silicon gel and human monocyte macrophages. This very interesting paper from Canada studied the interaction of monocytes and macrophages in histology, in cytokine analysis assay, in cell availability, as well as in electron microscopy. And the authors here provide evidence that monocytes engulf silicon bodies. And you can see numerous membrane-bound vacuoles here containing flocculent material that represents phagocytosed silicon. And what about silicon phagocytosed by macrophages and the process of inflammation? And what is the relation of inflammation with neoplasia? Is there any process? So in this case, we have to discuss what are the steps leading to inflammation and leading to anaplastic large cell lymphoma. When there is a capsulectomy performed, you have the chance to look at the capsule cells as well as the infusion cells. You can see that the capsule may have evidence of anaplastic large cell lymphoma cells. Not always in every part, so that the seroma, the effusion analysis, is more representative of the whole process. And we can see that a partial capsulectomy sometimes reveal the anaplastic large cell lymphoma or not. So it's more trusting to examine the effusion. But why in this should we the monocyte macrophage dendritic cell as the cell that presents in the effusion? Is this reactive? Is this inflammatory cell? How should we proceed? This is a very interesting review concerning the role of inflammation in lymphoma genesis and silicon implants, lymphoma, and lymphoma genesis. So the first step shouldn't be lymphoma. The first step, obviously, is inflammation. And schematically is depicted by the authors that silicon leads to inflammation and inflammation to lymphoma. In every step, the process should be evident as a pre-lymphoma condition. We can understand here that antigen-presenting cells like macrophages take up silicon particles. Then there comes inflammation, hypergamma-globulinemia, cytokine secretion, capsular fibrosis, T-cell proliferation, mutations, oncogenic, that lead to anaplastic large cell lymphoma. So a breast silicon implant ruptured or bleeding silicon outside and causing a seroma or an effusion with monocytes is not a neoplastic per se, but should cause anxiety concerning this process of inflammation, of course. These cases are rare, and as rare cases are not easily studied in controlled studies, an expert panel option is valuable, as we can see here. We have an expert panel that contains several parts of specialties like hematologists, oncologists, leukemia specialists, pathologists, immunologists, and epidemiologists. And they come up with several points of agreement or disagreement. And as you can see, their agreement points come up depicted for you here. And they agree that there is a positive association between breast implants and development of ALCL. And of course, ALCL is a late sequelae. It's not a primary sequelae of a prosthetic or cosmetic implantation. Sometimes more than 5 years, but certainly there should be an anxiety after the first 6 months. What is the other point? The other point is the diagnostic evaluation, which is the proper test. Patients with clinically evident seroma should be examined by aspiration and by cytology and flow cytometry. There should be a partial capsulectomy, of course, but the FNA analysis is primarily the first test to evaluate. Another question concerning is, what is the prognosis of this disease? as opposed to systemic anaplastic large cell lymphoma, which involves organs outside the breast and is ALK positive. We face a lymphoma here that is ALK negative, develops around the breast implant, and has generally a very good prognosis, simply by removing the capsule and the implant. And there's agreement between the experts that the prognosis is not a prognosis comparable to the other anaplastic large cell lymphomas. What is the opinion about macrophages' role in implant-associated anaplastic large cell etiology? So they agree that particles from the implant surface are taken up by macrophages, as we discussed before, starting the development of ALCL. And denatured self-tissue macromolecules like fibronectin, fibrinogen are taken by macrophages, potentially starting the development of anaplastic large cell lymphoma. But it's not enough. There is a T cell role, hyperstimulation occurring adjacent to the implant surface, and mutations in T cells, and findings of T cell journey arrangements that suggest that anaplastic large cell lymphoma develops for an expanded T cell clone. And what is the macrophage role in silicon particles in axillary lymph nodes of patients with ALCL around the breast implant? When biopsied, silicon particles from the implant are likely to be found in axillary lymph. So in this case, when we have to decide whether it is anaplastic large cell lymphoma, no, it's not. It's a seroma that is reactive with monocytes, macrophages, histiocytes. But the question is that how should we handle this case? How should it be handled? And of course, we come to the final option that point to an implant benign seroma, benign, but potentially leading to oncogenesis. So the question is, should the caring surgeon remove the implant and the capsule? Of course, the audience based their options to epidemiology, pointing to the most common implant-associated anaplastic large cell lymphoma, pointed to that looked like cells. But of course, in cases of these cells, if we look again at them, we can see foamy macrophages discussed by several followers. And they were correct that these are foamy macrophages, of course. And concerning flow cytometry helps us a lot in this case, and helps us a lot with monocyte macrophage indices. So morphology and flow together, to our opinion, led to a better diagnostic workup of this case.